Good afternoon, good morning. This is Frank Arko. Thanks for having me at the Asian Pacific Vascular Society, and thank you, Dr. Khanna, for inviting me to speak. I will be speaking to you on complex aortic coarctations. I wish I could be there. I wish I could be live as well, but based on the time zones, this would be very difficult for me as I have to travel with my family. So let's get into it. Coarctations of the aorta is an aortic narrowing, which is a congenital condition where the aorta narrows in the area where the ductus arteriosum inserts. It's considered a section of the aorta narrowed to abnormal width. There's a couple different types. There's a preductal, a ductal, as well as a postductal coarctation. We know that it's a known congenital heart defect. It's present in about 5 to 8%. It's also associated with bicuspid aortic valve in some 50 to 85% of the patients. It can also be associated with aortic valve as well as mitral valve stenosis. And it's important to take a look at family history or genetic factors to include Turner syndrome, for which we've actually treated several patients, as well as aneurysm formation over a period of time. Presentation can vary depending on age and symptoms, but in adults, often recoarctation after childhood repair often is certainly several of the cases that we get. Missed cases of native coarctation, exertional headaches, leg fatigue, and claudication. Complications that can occur if left untreated include systemic hypertension, premature coronary artery disease, ventricular dysfunction, aortic aneurysm, dissection, cerebral vascular disease, and also sudden cardiac death. Because of the risks associated with repair, treatment should, in my opinion, and our team, be performed at high volume centers. There are a couple different options, and again, I'm mainly talking about adults or larger individuals. I have really no experience with the pediatric population, but treatment options include serial balloon dilatation, stenting, bare metal only, and then lastly, stent grafting. So what exactly are the devices that can be used? Certainly there's balloon expandable stents. We've actually gone away from those and gone more to covered self-expanding stent grafts, and I'll give you my reasoning why and some of the data that we've looked at. But certainly covered stent grafts have increased in the last decade for coarctation treatment. Covered stent grafts have been relatively limited to the treatment of secondary pathologies or complications that have arisen from the primary repair. Given some of the significant advancements made in covered aortic stent grafts, treatment for adult coarctation is becoming a bit more routine. These advancements include integrated device delivery systems, use of self-expanding metal technologies, including nitinol, more accurate delivery technology, as well as low profile. Here's some of the benefits that I think that you have with a self-expanding stent over balloon expandable stent is you get continued dilatation of the stent graft over time, as well as the native aortic tissue. This has been some concern in the infrarenal component where the infrarenal neck will continue to dilate, and there's some concern about loss of seal. Well, that's really for aneurysmal disease, but this is what we really want to try to achieve in patients with coarctation, this sort of continued expansion over time to not require it to be quite as aggressive during the initial procedure, but with a period of time, you'll get to the desired size that you want. When you take a look at complications, certainly complications can arise when you're using balloon expandable stent grafts or covered stent grafts, including rupture of the aorta can be fatal, but is rare, less than 2%. Risk of stroke. Coverage of vital collateral branches. I feel that once you get to coarctation, these branches are not as important because you're removing the pressure gradient. You can certainly have, with the larger devices, delivery system withdrawal complications if you don't pre-dilate the coarctation prior to putting the stent graft in. There's a risk of retrograde dissection, but that risk I've not seen in my own hands. And then certainly the risk of graft migration, but these devices being 10 centimeters, when measured correctly, should really eliminate that risk. We've taken a look at our experience. We've actually probably now have 30, but this trial actually included only 22 patients, but with long-term follow-up. Median age of the patients that we treated was 47 years of age. 50% of the patients had a prior repair of the coarctation. Indications for repair included evidence of heart failure or left ventricular hypertrophy with a gradient of greater than 20, pseudoaneurysm or aneurysm formation, refractory hypertension, and or severe claudication. Stent grafts we utilize were the Valiant stent graft in the majority of the patients, serial balloon dilatation in all cases prior to the stent graft placement. I think that this is incredibly important because you can get the device to track through, but if you do not predilate that lesion, the recovery of either one of these two devices will be difficult to do because the narrowing will be even more narrowed with the stent graft in place. The majority of these cases were done with a single stent graft. Median hospital stay is quite short. It's a safe procedure. Typical hospital stay is about 2 days. Median follow-up for these patients that we're looking at is 3 years. Again, 100% survival, no risk of stroke, no risk of retrograde type A dissection. Reintervention rates you can see here, some for access-related complications, and then one with an endoleak. You can see here that we've got very good results, both intraoperatively and then long-term. But again, here we've got complete resolution of symptoms in all patients with no recurrence. Pre-treatment gradient was markedly reduced right at the end of the procedure, roughly about 35 pre-procedure going in and about 5.7 at the end of the procedure. We aim to get the gradient less than 10 and then let that stent graft dilate over a period of time. Again, you can see here that there's continued improvement in the systolic blood pressure as well as the diastolic up to 1 year's time, where we can really get these patients normotensive with very few medications. We have actually been able to drop the medications down by about one single one. Again, this was statistically significant. Here's really where the important data lies. Here you can see pre-op the average size of the diameter of the aorta was 11. At 30 days we got that up to 18, but you can see here we have continued expansion of the size of the coarctation up to nearly 20 millimeters, which is the size of a normal aorta in most of these individuals, and that's with no further re-interventions. You also get remodeling, both positive remodeling, both in the ascending as well as the descending, where that dilatation post-coarctation really begins to come back down to normal size, down to about 27 millimeters. So here's a couple of cases. This is a 28-year-old male, significant hypertension, sort of discovered while going to the dentist, referred for endovascular repair. You can see this coarctation right here. Here's a 3D reconstruction, really demonstrates this quite nicely. Almost has an almost has a look of a incomplete arch, if you will, but we actually saw and found that there was a very small lumen. But again, here you can see the size of that aorta is 2 millimeters in diameter. Proximally and distally, you can see the sizes there as well. Again, the importance of this is to cross this lesion and then dilate it. Again, we can see we pre-dilate this typically with 10s and 12 millimeter balloons. I feel that that gets me enough space to get the delivery system across. Oftentimes you have to cover the left subclavian artery and do a carotid subclavian bypass. And this one, this coarctation, I felt was far enough away that we did not have to cover the left subclavian. If you have to cover it a little bit, that's fine. You can see again just how large it is. You could drop that across 50% and the flow into the left subclavian would be just fine. Again, here you can sort of see what we've got. Very nice result. Nice opening. Again, that was 3 millimeters. We've got that with a 22 millimeter device in place. Here's the IVUS follow-up of that. Again, you can sort of see, here's the device coming through. You can sort of see how that gets narrowed. Again, our gradient had dropped down to less than 10, so I did not dilate it anymore. And I'm going to let that stent graft sort of dilate up over time. This is the beauty of that. So here you can see we did not dilate this anymore, but at 3 years, we've got very, very nice positive aortic remodeling with no evidence of coarctation, no further re-interventions. So in conclusion, aortic coarctation can be successfully treated with TEVAR. Benefits continue beyond initial resolution of symptoms. Mortality and re-intervention risks are low. Treatment should be performed at high-volume centers with a multi-specialty approach, including vascular surgeons, CT surgeons, congenital heart specialists as well. Thank you very much.